সম্মানিত চিকিৎসকবৃন্দ, জেনেসিস অনলাইন ইউনিভার্সিটিতে আপনাদেরকে স্বাগতম। আমাদের সম্মানিত স্যার, আমাদের সকলের পরিচিত স্যার, আমাদের ডক্টর এম এ বি সিদ্দিক স্যার আমাদের আজকের ক্লাসে যুক্ত হয়েছেন। আমরা স্যারকে স্বাগতম জানাচ্ছি অনলাইন ইউনিভার্সিটির পক্ষ থেকে। স্যার শুরু করেন স্যার।
Thank you very much. Dear student, welcome you all. Today's our third OSPE class. Today we will discuss about the different appliance in surgical ward, and it is one of the station in OSPE out of 10 station. So today we will discuss the different appliance used in surgical practice. So first of all, the slide show that is what is the structure, identify the object. The question may be like that way: identify the object. This is an intravenous cannula to show in slide, and there are four different colors. There is a color code. This color code is universal all over the world, and this color code indicate the diameter of the cannula for intravenous use. This is one of the most common use appliance in hospital admitted patient, and the color code is universal and it indicate the diameter, and this diameter is universal all over the world. So if we look at this slide, that the yellow code is used for a cannula that's diameter is 24 gauge. This is the French gauge, and also the maximum flow rate per minute is 13 ml per minute. So increasing the number is the actually decreasing the diameter. 24G is the lowest diameter, and it is the less than the 22G, then the 20G. So the increasing number of the gauge, the diameter of the cannula is decreasing. So the blue color is used for 22 gauge, and the maximum flow rate is 31, and the pink color is used for 20 gauge, and the maximum flow rate is 67. This is the most commonly used cannula for adult, but the yellow is most commonly used cannula for children, and the green also commonly used in ward, especially the gynae ward, and this gynae ward, and this is the 18G, and the diameter is more than the 20G, and the maximum flow rate is 103 ml per minute, and gray and orange are also. But the most commonly used cannula in hospital ward is pink and green, that is 20G and 18G. So the question may be like that way. Identify the object, mention the part of it, name 3 IV fluid, and what complication may arise from it. So in OSPE, we will written in answer is written in word. I remember in every class that in OSPE the time is limited, so you shift to answer the question and you write the answer in word, not in sentence. But for the discussion purpose, I will discuss all things in elaborate way. So the indication of the the question may be like this: what are the indication of this appliance, or what are the indication of this instrument is the administration of anesthesia. Administration of before any anesthesia, even in local anesthesia, the IV cannula should be used, because there are some adverse effect in local anesthesia that required urgent administration of the drug. So administrative anesthesia, it is must for spinal anesthesia and general anesthesia, and even in local anesthesia it should be used. If there is a crisis arise and need a urgent or emergency drug, in this case you cannot you have any time enough time to introduce the cannula, so it will introduce before starting a local anesthesia. It is a good practice, and it will be it should be. Administration of fluid, any fluid in the surgical ward or medicine ward or hospital admitted patient, like normal saline, Hartmann solution, DA, dextrosine aqua, dextrosine normal saline, this fluid can be introduced through this cannula. Administration of medication, that is drug, intravenous drug, antibiotic, antibiotic, chemo, chemotherapy. Even in chemotherapy, this medication of intravenous medication should be used by IV cannula. Administration of blood and blood product need cannula, and it is better for 18G for administration of blood and blood product. And radiological imaging using IV contrast, we discussed in our previous class that IV contrast use in some CT scan. For IV contrast, we use this cannula. So there are various various indication for using of IV cannula. Using of IV cannula, there are various way of using of IV cannula, and it is one of the most appliance used in hospital admitted patient. So what are the contra indication of the IV cannula? The site close to infection, the site close to infection, it will be a contraindicated. Vein of fracture limb, where there is an AV fistula present, where there is an edema or affected site of the CV cerebrovascular accident, side of mastectomy. If you use this cannula in mastectomy, there is problem both in mechanical and also physiological. So extra care, and also extra care should be taken on patient with bleeding, clotting disorder, and on orpharing. So what are the site? There are various site used. The most commonly used a cannula in hand, back of hand, forearm, and antecubital fossa. The vein used in cephalic and basilic vein, but in case of children, we can use this cannula in leg or even in head. Area to be avoided, what are the area should be avoided to where to IV cannula? Area of joint flexion, when there is joint flexion, there is a joint flexion. If you use this cannula, patient cannot flex the joint, and he feel pain during movement of the limb. So you must avoid the joint area, and the sclerosed vein or hardened vein should be avoided. Major vein near artery should be avoided, and vein in lower extremity usually avoided, but sometimes it required. An area of surgery, a small vein and previously cannulated vein should be avoided to introduce IV intravenous cannula. Location of vein, I already mentioned the cephalic and basilic vein. The most commonly used vein is cephalic vein and basilic vein. This is the most commonly used vein. We using the IV cannula, and also in hand we use this IV cannula. This is the cephalic and basilic vein, and usually in dorsal vein we cannot use. Usually we are not use in dorsal vein for IV cannula. The most commonly is the cephalic and basilic vein, and also the in hand the vein of the hand. So cannula type we already mentioned. The color code, the color code is universal in all over the world, and most commonly use cannula is the for adult in 18G and 20G. In case of 18G, we usually use the blood product, delivery of irritant medication, major surgery, and contrast study. When need rapid fluid, when patient is in shock, patient required rapid introduction of the fluid. In this case, we use usually the 18 gauge cannula. But in usually without any emergency, we use the 20G in our ward. So, and also the 24G, the most commonly used cannula for children. So this is the part of the cannula. This is an actually this is the different part and different huge part. This is the catheter, this is the bushing, and this is the valve and injection port. We use this port. This is the very important. We use this port for injection. This chamber, this connected with the set, saline set, the saline set. So in this case we can use the saline set also, but we can use easily this in injection port site. And there are other uh, part of the cannula. There are so many part of the cannula. So what are the complication? There are many complication. There are many complication of the IV cannula. It may be a local complication or it may be a systemic complication. The local complication may be infiltration, extravasation, thrombosis, thrombophlebitis, and phlebitis. Thrombophlebitis, one of the most common complication of the intravenous cannula. And the question may be in your OSPE, the what are the complication of the cannula. You put just what are the three complication, like that, that name mention the three complication of the IV cannula. You may you write a answer like that: thrombosis, thrombophlebitis, phlebitis, or systemic like embolism, hematoma, systemic infection, spit shock, circulatory overload, and allergic reaction. So when you need long term use of the cannula, it should be changed every 3 days. It is very ideal to change the cannula every 3 days. Otherwise it will not helpful, rather it's harmful for the patient, and chance of infection is more. So you should we should cautious about these things to when patient need more than 3 days of IV introduction. So the next appliance, we one of the common appliance used in surgical practice. This is the catheterization. This is the catheterization. This is the catheter. The catheter may be there are different type of catheter. This may be a bi-channel catheter, tri-channel catheter, plain rubber catheter, metallic catheter, and the use are different in different type of catheter. If you need temporary evacuation of the bladder, if you need temporary relief of the bladder, then you can use plain rubber catheter simply, if not required for the continuous time. But if need continuous catheterization or continuous bladder evacuation, then we use the Foley's bichannel catheter. Foley's bichannel catheter, the Foley's the first introducer of the catheter. But in case of tri-channel catheter, it is also for irrigation. It is also for irrigation in case of hematuria, patient of hematuria like benign enlargement of prostate, or patient with bladder cancer, that the continuous hematuria. This hematuria may clot and may block the catheter. In this case, we use tri-channel catheter for irrigation. I mentioned the part of the catheter. There is the picture show this is the balloon inflation. This part in we use water, distilled water. We use distilled water to inflate the balloon. This is and the inflation state and this is the deflation state. When inflate it, it retain, it cannot dislodge from the bladder, it retain within the bladder, and this channel is used for this inflation of the distilled water. And this is the catheter proper, and this channel is the urine drainage port. Urine drainage is through this port, and this is the opening for urine, and urine comes through this opening, and these are the part of the catheter. So what is urinary catheterization? A latex, polyurethane, or silicone. The urinary catheter is made by latex or silicone. When you need catheterization for prolonged time, it is better to use silicone to prevent blockage or retention, and even infection rate is less. So in case of when you need catheterization prolonged time, the silicone catheter is better than the latex particle. But when you need catheter for a short time, you can use the latex particle of catheter, and this catheter is introduced into a patient bladder via the urethra. Catheterization allow the patient's urine to drain freely from the bladder for collection. It may be used to inject liquid, used for treatment or diagnosis of the bladder condition. Even we can use this catheter for diagnosis of the, we use dye for diagnosis some disease by this catheterization. So already mentioned there what are the type of catheterization. Indwelling catheter, when you need catheterization for continuously, but when you need catheterization for intermediate time, then you use the intermittent catheterization. So it is one of the most commonly used appliance in surgical practice. Indication of catheterization: what are the indication? To drain bladder, to monitor output, urine specimen, and diagnostic study. So what are the condition you drain? It is due to retention of the bladder, due to neurogenic bladder, obstructed bladder, or due to clot. Or in case of unconscious patient, or to we use catheterization and monitoring of the output. In case of trauma patient, in medical condition like sepsis and congestive heart failure, in this case we can monitor urine output by catheterization to amount of the collection in the urine bag by monitoring the patient urine output. So urine specimen, we can use this catheterization to use urine specimen for examination and diagnostic study. Also residual urine or renal function or urodynamics we can use in this indication for catheterization. There are another type of catheter that is called condom catheter or external catheter, that usually used in unconscious patient of incontinence. Whether there is an incontinence, we use this catheter of condom catheter or external catheter. It helpful for prevention of infection. The catheterization, when introduced within the bladder, there is chance of infection, but in case of external catheter, the chance of infection is reduced. So in case of incontinence, not retention but incontinence, in case of incontinence patient, we can use the condom catheter or external catheter. So what are the contraindication of traumatic catheterization? There may be what are the contraindication of catheterization when there is an history of trauma? Because in case of history of trauma, there is a chance of rupture urethra. But when there is an incomplete rupture urethra, uh, you if you try or introduce catheter, it become complete. So you not better not to try catheterization in case of trauma patient when you suspect rupture urethra. So it should be avoided. And how will you diagnose the rupture urethra? That is the mechanism of injury: blood at meatus, high riding posted by digital rectal examination, and perineal hematoma. When these symptom are when these feature are found on examination, it is better to avoid catheterization. So when any of these findings are present in the setting of possible trauma, a retrograde ureterogram should be performed to rule out a catheter tear prior to placing a catheter into the bladder. But if you introduce catheter at this time, when sometimes the incomplete rupture may become complete. So the next is the what are the complication of catheterization. There might be short term complication or long term complication. The short term complication is trauma, false passage, hematuria, and urinary tract infection. And long term complication may be colonization of the bacteria, urethral slapping, malignancy, stone, hematuria, obstruction, and stricture. These are the complication of catheterization. It may be a question, what are the complication of catheterization? So the catheter size is in the French size, and the circumference in millimeter. The French 10 FR circumference is equal to 3.14 millimeter diameter. So material may be latex and silicone or Teflon. So equipment of catheterization very important. If you not arrange all the things in during catheterization, you may go further and further, once after once, and it will be very you may puzzle, or you may uh, irritate for catheterization. So everything should be kept in your site of catheterization, like the catheter, the drop, gauze, lubricant, the appropriate site of the catheter, antiseptic solution, sterile glove, and the uh, distilled water, and collection bag, and xylocaine jelly. This is a minor surgical procedure, and this catheterization is not a simple procedure. It's a very important procedure, though it is minor, but it become major procedure. I have seen several times during catheterization they are not introducing properly, not introducing up to the bladder, and before going to bladder, inflate the balloon, and there is a rupture of the urethra. And this is the very sorrow condition. This is the very pathetic condition of the patient. This patient, the rupture urethra patient, is suffering, is the long term suffering, is the very important part of catheterization. So you not casual to introduce catheterization of a patient. It is the life of a patient. If you not introduce properly and there is a rupture catheter, it will be very pathetic condition of the patient. So every doctor, every student should be cautious about catheterization, not things that it is a simple, not things that it is a very easy. You should introduce the catheterization properly, and it introduce within the bladder when there is urine come out, or if introduce totally, then you inflate the balloon. Otherwise, by incomplete introduction of the catheter and if you inflate the bladder, if you inflate the balloon before introduction of the catheter, there is a rupture on the prostatic urethra, and it is very pathetic condition of the patient. So everyone should be cautious about during introduction of the catheterization. So question may be like that: identify the object. What are the parts of this object? Write three indication of its use. Name two conduct indication of its use per urethra, and how it is sterilized. It is sterilized by gamma radiation. So all question already discussed about catheterization. The question may be like that way. So you should memorize all the things in OSPE. The next appliance, one of the next common appliance used in the feeding tube or Riles tube. It has two use for feeding of the patient, and also use for suction or lavage of the stomach. So it is commonly used in surgical practice, and it is also color code, and the color code is universal for all. But we use in our word is like 14, 16, even also the most of the commonly use 14, 16 and 18, but the smaller size is also used in our surgical practice, though not commonly, but variably it is used. So if you look at the picture, there is a the pore within the feeding tube is there's several pore, but not so many, and pore size is usually larger than drain tube. So indication, what are the indication of the drain tube? The indication of the drain tube is gastric decompression. Gastric decompression. Sometimes we, in case of postoperatively or preoperatively, in case of intestinal obstruction, of several cause, we decompress the stomach to decrease the pressure on the intestine. That may be helpful, even may be curable for the patient. Some intestine, if the idiopathic cause of the intestinal obstruction, so it also helpful, it also therapeutic for this patient for gastric decompression. And the garbage, that means feeding, there is several times we use feeding purpose for Riles tube or feeding tube we use for the feeding purpose. In several indication we use feeding by this tube. And also the gastric lavage, that is the irrigation or dilution of gastric content. It is one of the common use in surgical ward for before gastric surgery. In case of gastric surgery, especially the gastric outlet obstruction due to pyloric stenosis, or gastric outlet obstruction due to carcinoma of the stomach. In this case, the gastric is usually hugely distended and edematous, and there are some sorts of gastritis in the stomach. So we use this lavage by normal saline. We dilute of the stomach by normal saline, and after that we suck out the content of the stomach to reduce the content, to reduce the content of the stomach, to reduce the content of the stomach. So it will helpful for postoperatively, because the patient have gastritis, it reduce the gastritis. Also the stomach wall is edematous, so this edema reduced by suction, and also mm, by suction, and also it helpful to secure anastomosis. It helpful to secure anastomosis for lavage purpose. And there are some sorts of to reduce the anastomotic leakage by this lavage. And also sampling of gastric content for analysis in case of children. If you diagnose tuberculosis, you cannot take sample by a children, so we introduce this tube to collect stomach content and analyze for tuberculosis. This is also one of the use of uh, feeding tube.
স্যার প্রেজেন্টেশনটা একটু বড় করলে ভালো হতো, রিকোয়েস্ট করেছেন একজন ডক্টর। ওই যে ফুল প্রেজেন্টেশন ভিউতে দেন নিচের দিকে।
আচ্ছা, এটা একটু ইয়া হয়ে গেছে।
হ্যাঁ, এবার ভালো দেখাচ্ছে। জি স্যার, থ্যাংক ইউ স্যার।
আগে মনে করে দিলে একটু ভালো হতো।
জি স্যার।
একজনকে নৌরে নশমিকে ওয়েটিং রুম আসতে যাচ্ছে বারবার।
স্যার কোশ্চেন করার জন্য যারা জয়েন করছেন তাদের কোশ্চেন গুলো আমরা শেষে নিব স্যার।
আচ্ছা আচ্ছা,
জি স্যার।
ওকে। সো এটা তো আমাকে ডিস্টার্ব দিচ্ছে। তাকে একটু বলে দাও যে অ্যাডমিট না হতে। The contraindication.
সেটিংটা অফ করে রাখছি, আপনাকে ডিস্টার্ব করবে না স্যার।
So contraindication the basilar skull fracture. In case of skull fracture, it is contraindicated because the risk of NG reaching the brain and it damage to the brain, and facial fracture, risk of cubiform plate disruption and NG reaching brain. This is also contraindication. And obstructed nasal passage, if in case of patient have DNS or others some sorts of problem, hypertrophic inferior turbinate, you look at the nasal nose orifice to the most opening, the most wide side. You introduce the most wide side of the nasal orifice. And in case of caustic injection, corrosive injection or esophageal stricture, it is contraindicated to introduce a NG tube because there is a chance of perforation. And coagulopathy, uncontrolled epistaxis also contraindicate. There is an uncontrolled bleeding may happen by due to trauma. So these are the contraindication of the uh, NG tube. And marking, there are some marking in the NG tube. There is 4 marking in the NG tube. First marking is the single line 40 centimeter from the tip of the tube, and when you introduce 40 centimeter, it indicate you reach on the gastroesophageal junction. The second marking is the 50 centimeter from the tip, and when you introduce 50 centimeter of the tube, it lies on the body of the stomach. And third marking is the 60 centimeter from the tip of the tube, that indicate you enter into the pylorus of the stomach. And the fourth one is 70 centimeter from the tip of the tube, and it lies at the duodenum. So when you introduce up to the 70 centimeter, you indicate that you reach up to the duodenum. This marking is helpful for what purpose you want to introduce. It is one of the misconception that if you in case of feeding purpose, it is if you reach to the body of the stomach, it is enough for feeding purpose. But for suction purpose, you must reach up to the pylorus. You must up to the reach of the pylorus, because if you not reach up to the pylorus, if you reach up to the esophageal junction or body of the, you cannot suck out the content that retain within the pylorus. So you, in case of feeding or in case of NG suction, in case of suction, you introduce more than 10 centimeter than feeding purpose. So these are the appliance that required. My question may be like that: what are the instrument, what are the arrangement you need for NG suction or NG feeding? Like that, the gloves, sterile gloves, aseptic syringe or nasogastric tube, water-based lubricant jelly, cup of water. Because when you introduce the NG tube, you frequently tell patient to take for swallowing, and this time you can give the water to the patient, and bile bag or drainage bag, and also the stethoscope, and the securing the device by the tape. All things. The question may be like that: what are the things you need for introduction of the NG tube? So this picture show that how will you marking the tip of the nose for the tragus, and then tragus to the umbilicus. This is for the suction. But if you want to feeding, you can make this up to the epigastrium, it is enough. But for suction, you must make a marking from tip of the nose to the tragus, then up to the umbilicus. So it is very important for suction purpose, and the difference between the suction purpose and feeding purpose. So how will you confirm uh, the tube is reached to the stomach? Sometimes the tube may be crinking, tube may be crinking within the esophagus or stomach, or maybe may introduce into the uh, epiglottis to the larynx. So how will you confirm that it is goes up to the stomach? When there is a content come out through the tube, it is also one of the indicator that you reach the stomach. And also to you uh, by a syringe, 50 cc syringe, you introduce the air very swiftly, and then stetho place on the epigastrium. If there is a gargle sound, that indicate the tube is reached up to the uh, stomach. But when is introduced into the larynx, the patient vigorous coughing and irritating, and you cannot proceed further. And also, if you put the tube on a glass of water, there is an air bubble on the glass, that indicate that tube introduced in the larynx. So this in case of introduction of the larynx, you must immediately withdraw the tube and then try further for few minutes after. So complication, there are so many complication, but in your exam there may be a write 3 complication or 4 complication of the NG tube. The complication during insertion, during use, during removal. So during insertion there may be a malposition, there may be epistaxis, vomiting and aspiration, placement into the anterior canal fossa in case of base of the fracture. But if you think that there is an skull fracture, you would not introduce the NG because it is contraindicated. And also the esophageal and posterior pharyngeal perforation also happen. If you introduce it, is if you feel resistant to introduce, you cannot push further. So, and during use, there may be sinusitis, reflex and aspiration, unplanned dislodgement or migration, blockage, kinking, knotting. And during removal, mucosal adherence and trauma, failure, and dislodgement of tube. These are the complication of the NG tube. So how will you confirm? Already mentioned, the aspirate with syringe, aspiration of gastric content or bile, auscultate on epigastrium as air is injected into the tube with 50 ml syringe, the audible gargling sound. This is the another appliance we use surgical practice. The common one of the is also another common appliance. The difference between feeding tube and this tube is there are several, so many pore within the tube, and the pore are so small than the feeding tube. This is actually the drain tube. This is actually the drain tube, one of the common tube, used in surgical practice. The difference between feeding tube and drain tube is that there are in drain tube there are so many pore, and the pore is smaller than the feeding tube, but the in feeding tube the pore are is fewer than the drain tube, and also the pore size is larger. So definition may be like that: a surgical drain is a tube used to remove pus, blood or other fluid from a wound. Drain inserted after surgery don't result in faster wound healing, but are sometimes necessary to drain body fluid which may accumulate and in itself become a focus of infection. Drain may be hooked to wall suction, a portable suction device, or it may be left a drain by gravity. Accurate recording of the volume of drainage as well as the content is vital to ensure proper healing and monitoring for excessive bleeding. Depending on the amount of drainage, a patient may have the drain in place 1 day to weeks. Drain are available in different size. So the use of drain tube is remove any intraperitoneal or own collection of ascites to reduce the gap, and the collection of ascites, serum, bile, chyle, and pancreatic or intestinal secretion act as a signal for any postoperative hemorrhage or anastomotic leakage, provide a track for later drainage. In case of intestinal anastomosis, there is a signal on the drain tube. There is a content like the intestinal content. If you think that if you confirm, if you identify the intestinal content by seeing the color, the odor, whether it is the intestinal content or not. If there is a content like intestinal content, there is a chance of intestinal leakage. This is an alarming sign of leakage of the intestine. In this case, you can take major decision, you can take prompt decision of the patient by seeing the patient, whether you open or whether you continue the conservative treatment by seeing the color, odor, and amount of the content. And also the postoperative hemorrhage, if you think that there is an hemorrhage, blood continuously come out through this drain tube, it indicate that there is an active bleeding within the operative field. You can take immediate decision by seeing this signal on drain tube and provide a track for later drainage. It is actually in case of chloidicolithiasis. Following chloidicolithiasis, we introduce the T tube. This T tube, when there is an retained stone within the CBD, this T tube can retain, or the T tube track is used for later drainage of this for this stone. So ideal drain. What are the ideal drain? But how? What are the criteria of ideal drain? Firm, not too rigid. It should not be too soft, as it may twist or kink or become blocked, or but it is not too hard. It will be smooth. It should be resistant to decomposition or disintegration. White and patent enough prevent easy blockage, and it should be non-electrolytic, non carcinogenic, and non-thermogenic when used in vascular surgery. So what are the type of drain tubes? The surgical drain can be open or closed, or it may be active or passive. The passive drain, that type of drain that simply act by means of the capillary action or gravity. Example, corrugated rubber drain, Penrose drain, very soft rubber tube with gauze, some drain. And also these drain are used when drainage fluid is too viscous. We use this passive drain. Active drain are the drain that are aided by active suction. Example, Romovac drain, Humovac, Surgivac. These are the active drain. Actually, this used in negative pressure. You act as a negative pressure. We use this active drain. Intraoperative care. What are the intraoperative? Place such that they take the safest, shortest route possible. Should reach the deepest and most dependent part of the cavity around. Tube should remain free of kink, debris, and clot. Should be secured well to avoid falling off or its migration into the cavity or erosion or surrounding, and should be secured by a suture material. Drain should be lower than the incision at all times. Among should be always in the lower side of the incision, not upper part of the incision. Secure a drain. We usually use suture material for securing the secure a drain. Postoperative care. The postoperative care depend on the purpose and location of the drain. Some drain, uh, sometimes there is an addition on the following laparoscopic cholecystectomy, we use drain, and it will remove after 24 hours. Some case of drain, like following intestinal anastomosis, we usually remove drain after oral feeding of the patient. So, and it also depend upon the collection. There is, when there is an less collection is decreasing and more less than 25 ml, and it is the serous fluid of the peritoneal fluid, then it will remove the drain. But if we keep drain, it will come out, that there is the peritoneal fluid come out every time. But when this amount is reduced less than 25 ml, you should remove the drain tube. So it depends upon the type of the surgery, the color of the drain, the amount of the drain. So it is important when you remove the drain. So complication, there are so many there are some complication, and some surgeon argue that the drain is not helpful, rather it harmful. So the drain, use of drain is decreasing day by day. The use of drain is decreasing day by day. Some operation that previously we use routinely this drain tube, but in nowadays we not use this drain routinely. So there's complication, may be pain, irritation, bleeding, perforation, or injury to adjacent structure. The early complication may be occlusion, leaking around drain, displacement, infection, loss of fluid and electrolyte and protein. Late complication may be pressure, necrosis, fistula, scar, hernia. Complication, though I never seen hernia following a drain tube site. Complication during removal, maybe pain, infection, injury to adjacent structure, or retain, maybe retain tube, especially in case of T tube. There's sometimes the retain tube within the CBD. So another drain tube, another appliance, it is also one type of drain tube also, the T tube. We already discussed our previous class the T tube. So I will summarize the this section. The T tube, this is actually a T shaped T tube. It has a short limb and a long limb, and two angle. One is obtuse angle and another is acute angle. The acute angle in the inferior side and the obtuse angle in the upper part, and it introduced following a colodoco lithotomy, and this tube is in outside from the skin, and this tube actually routinely used in previously, because there is no in our country there is no there is some, though nowadays in some area colodoscope is available, but in previously there is no colodoscope. If there is no colodoscope, then there is a chance of a stone within the CBD. But if you remove the stone, if you not confirm that there may be a retained stone, then we introduce this T tube. It will helpful to see the retained CBD stone, and this tube also helpful to diagnose, though it is also helpful to diagnose whether there is any retained stone or not. And also this tube also helpful for therapeutic use. But nowadays, as ERCP is available, so so the T tube track used for removal of the retained stone is reduced. So if there is an stone in the impacted on the lower part of the CBD as ERCP available, it is better to remove. It is better to remove the stone by ERCP. So nowadays the use of but in previously this track also used for removal of the T tube, that is called Barhani technique. Now it is almost obsolete. So what are the use? Following colodocolectomy and following repair of bile duct. Sometimes there is an injury following laparoscopic or open cholecystectomy due to moribund anatomy. If you find that find this injury perioperatively, you repair this injury over a T tube. So it is also helpful for repair of the bile duct. Why this is this use? Because if you not use this T tube, there is a chance of stricture and reduce the diameter of the CBD. And patient postoperatively patient develop moribund condition of cholangitis, several time of cholangitis, recurrent cholangitis. So to every step should be taken to prevent constriction of the CBD. For this purpose, we use T tube to repair the bile duct. Another appliance is infusion set. Another appliance is infusion set. This is the infusion set. There are so many part of the infusion tube. This is the spike, air vent, drip chamber, solution tube. This is the regulator, how many drop you want to introduce. This is the when I mention when we I mentioned the cannula. This cannula is introduced with by connector this connector, and this side you can inject when there is a rapid need of injection, like during anesthesia. You may introduce injection through this side. This is the rubber and latex particle. So look at this chamber. There is no filter. There is no filter at this chamber. What are the difference between infusion? How will you identify infusion set with the transfusion set? Look at this picture. There is an filter. There is an filter, but in here picture there is no filter. This is the difference between the transfusion set. This is the transfusion set, and this is the infusion set. You never introduce blood or blood products by this set. You must use blood or blood product by this transfusion set when there is an filter, because in case of blood transfusion there is a chance of clot. There is a chance of clot, and this clot mm, uh, 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 very harmful for the patient. So to filter this clot, we use this transfusion sets. That this is the difference between infusion set and transfusion set. So name three common fluid used in what? I think you should know the fluid like Hartmann solution, Linzer lactate solution, normal saline, dextrose in aqua, dextrose in normal saline, etc. And indication of IV fluid, there is hypovolemia, hypovolemia, diarrhea, vomiting, postoperatively monitoring of the patient for maintaining the channel. These are the use or indication of the IV fluid. Another appliance is what is this? This is an oropharyngeal tube. This is an oropharyngeal tube. Oropharyngeal airway tube. This oropharyngeal airway tube, the question may be like that: identify the object used to make airway clear to prevent tongue fall back of the tongue, postoperative patient, unconscious patient, help in collection of secretion. This tube is introduced oral route, oropharyngeal, and this is helpful. This is helpful especially in postoperative patient. There are many recorded death following postoperatively due to high sedation, fallback of the tongue, and fallback of the tongue, and that blockage the oropharynx. And this oropharynx due to blockage, and as the patient is unconscious, or as the patient is deep sedation, he cannot say something. And if you not follow up this patient, not look at this patient may die. And there are several recorded death following postoperative patient by tongue fallback. You can prevent this oropharyngeal tube, this tongue fall. This is very important, and I think every major surgery, following every major surgery, you use this oropharyngeal tube uh, postoperatively for few minutes, for sometimes. So due to shortage of time, I will conclude the session after discussion on the suture material, and our next class will continue with others appliance and also the others topics. So I will conclude after that suture material. The suture material may be absorbable suture or non absorbable suture. The absorbable suture may also natural absorbable and also the synthetic absorbable suture. The natural absorbable suture is plain or chromic catgut. The synthetic absorbable suture is polyglycolic acid, that is known as Dexone, polyglactin, that is known as Vicryl, and polydiagonal suture, that is known as PDS. Non-absorbable suture, this result remain in the tissue for indefinite period. Absorbable, that means it will absorb, but in non-absorbable suture, it may remain within the tissue for indefinite period. Depending on the source, this suture may be natural absorbable suture. The silk is the natural non-absorbable suture, and the synthetic non-absorbable suture are the natural and synthetic. The natural are the silk and synthetic are the material in our surgical practice. Look at this picture. This is the indicator. This is the indicator thickness of the suture. This look the number one, the thickness. The zero means 10. If you 1020, that indicate 10203040. That means zero is number of zero increasing. That indicate the diameter of the suture material is decreasing. So the when 10 compare with the 20, the 20 is more less diameter than the 10, but 12 is the more diameter. The when the increasing the number, increasing the diameter of the suture meter, increasing the number of the zero, decreasing the diameter of the suture material. That means the 1020304050, that is decreasing the diameter, but 12 means the increasing the diameter. So this is the code number, this is the code number. And type of suture, this is the type of suture, what type of suture, and this is the company who made uh, this suture material, and this is the lot number to prevent the actually this lot number and other things is used for to prevent the copy of this suture material. And the manufacturing license expire date is very important, and the foil pack, the main important things. And also the this is the needle, this is the needle, whether it is cutting, whether it is round body, whether the this is the indicator, that is this indicator indicate that is the Mercedes Benz indicator. This is the actually true cut, a taper cut or a taper cut needle. But when it is round, this is the round needle, and this is the needle size, the how many the shape of the needle. This picture indicate the shape of the needle. This is very important for practical purpose, which needle or which suture you require, and all information is gathered on this uh, pack of the suture. So characteristic of the catgut derive from submucosa of sheep's intestine or serosa or cattle intestine. It is 99% collagen. This is absorbed by process of enzymatic digestion by proteolytic enzyme contained in the polymorph and macrophage. Catgut is easy to handle and not well. The knot is better by catgut. Knot is better by catgut. So use of plain catgut used during circumcision to suture the cut margin of the prepuce, used in repair on wound of lip and oral cavity. Very important. The catgut, as the catgut is plain catgut, is absorbed more rapidly. If we use chromic acid, we react with the chromic acid, the longevity of the catgut is increasing, and it is not suitable for circumcision, because if the suture matter is retained for more than 7 days or several days, that is very embarrassing, or that is that is not suitable for the patient, and use also in the lip and oral cavity. If we use the chromic catgut, it will uh, irritant for the patient. So in case of suturing on the oral cavity or lip, or during circumcision, we use plain catgut. But when the plain catgut is reacted with the chromic acid, the longevity is increasing, so it is used as like and vicryl. The most commonly used absorbable suture of synthetic suture is vicryl. So in case of chromic catgut, the use of chromic catgut and vicryl almost same. So what do you mean by an atraumatic suture? Atraumatic suture means that it not trauma to the tissue. It going in between the tissue, so that it not damage to the tissue. That is the atraumatic suture. The synthetic absorbable suture are that the common feature is that it is synthesized in the laboratory. This may be monofilament, polydiagonal, or finer vicryl, or polyfilament. They may be natural color or can be colored green or violet. They are twice as strong as compared to natural absorbable suture. They are absorbed by a simple process of hydrolysis and evoke minimal tissue reaction. They have excellent handling properties. Once tied, the knot are secured. The knot is secured is in case of uh, synthetic absorbable suture, and they are sterilized by ethylene oxide. I think time is over, so we will stop at this moment, and I will continue this session in our next class. Thank you very much.